I'm Dr. Lauren Streicher, and I'm the medical director of the Northwestern Medicine Center for Sexual Medicine and Menopause. Today, I'm going to introduce you to our staff of pelvic floor physical therapists and let them give you the inside information of what to expect. So let's start by just introducing yourselves.
Hi, everyone. My name is Toshi. I have a doctorate degree in physical therapy. I also have a pelvic rehabilitation practitioner certification. I have been a physical therapist for the past 8 years and a pelvic floor physical therapist for the past 5 years.
Hi, I'm Helene Bengtson. I have my doctorate in physical therapy. I'm also a board certified clinical specialist in both orthopedics and women's health. I've been practicing as a physical therapist for 6 years and as a pelvic floor physical therapist for 4 years.
Hi, my name is Catherine, and I'm a board-certified women's health physical therapist. I've specialized in pelvic floor physical therapy since graduating with my doctorate in physical therapy in 2016. I received advanced training in treating pelvic health dysfunction and lymphedema, and I'm extremely passionate about helping people recover from these conditions.
So Toshi, let's start with you. Before we get to what happens during a pelvic therapy session, can you give a rundown of the kinds of things a pelvic floor physical therapist treats?
So sure, pelvic floor physical therapy addresses issues in the areas of sexual, urinary, bowel, gastrointestinal, and general pelvic health. Examples are sexual issues such as pain with intercourse, orgasm, arousal, urinary issues such as incontinence, urge and frequency, unable to empty, maybe bowel issues such as constipation, straining, or pain with bowel movement, gastrointestinal issues such as bloating or pain, and then general pain conditions that can be in the low back, hip, vaginal, rectal, bladder region, or it can be even in areas of sits bones and your tailbone.
Is there anything you guys don't treat? But I want to circle back to something that you just kind of casually threw in there, and that's back pain. So many of our patients tell us, hey, you sent me to see the physical therapist because I had problems with urine loss or because I had pain with sex. And oh my God, now my back pain is gone, my hip pain is gone. All of that stuff is better. So Helene, kind of explain to us, why is it that someone goes in to get their bladder fixed and they end up getting rid of their back pain too?
So the pelvis is kind of the center of it all. So if I actually pull out a pelvic model, you can actually see. So we have our front side over here. This is our pubic bone. The back side, this is our back. So when you come into a pelvic floor physical therapist, we're actually treating all of these muscles that you see down below in red. But they're so very vastly close to both where our hip actually inserts and where our back is. And so therefore, sometimes we end up treating all of the above.
Everything's connected. I think that's what we sometimes forget, is that it all is related. All right, so let's get right to it in terms of what actually happens when you see a physical therapist. So Catherine, talk about when you see a patient for the first time. What's going to happen at that initial visit? What are you going to do when the first time this woman walks through the door?
Certainly, we get this question quite often. Usually tell people our initial visit to PT is a lot less scary than you may think. Pelvic floor PT people are sometimes a little apprehensive about coming in. So usually what we do at the first portion of our visit is ask questions related to symptoms. So we ask, what symptoms are you experiencing? What treatments have you tried? What are your goals for physical therapy? And really any other relevant questions about the pelvic floor and the surrounding structures, kind of as Helene was touching on. So these often include us asking some more personal questions too about the bowel, bladder, and sexual function, including questions about orgasm. We ask these questions because the pelvic floor may be impacting symptoms related to these areas. We also typically ask questions again about hip or back pain, medications you may be taking, any history of trauma, surgeries, sleep, stress levels, all things that can impact your symptoms as well.
Catherine, the other thing that I think surprises my patients is they'll say, oh my God, she asked me all about things like when I was a kid. Like, was I ever constipated when I was little? And what my bowel habits were then. Why do you ask stuff like that? Why is it so important?
So if we've had a chronic history of some of those activities, so say with constipation, if people have been straining for a long period of time, that can have a long-term impact on how those pelvic floor muscles are functioning, as well as might give us an indication about some behavioral things that we might address in PT, and are all things that are very relevant for us to know in our treatment plan.
So it's all part of the equation. So, all right, after you take this long history and you do all this talking, then you're going to get to the physical part of it. So, Toshi, when you first start your physical exam, you don't even have people take their clothes off, do you? Can you talk a little bit about that initial exam?
Yes, so for the physical exam, for the initial component, absolutely all your clothes can stay on. At most, maybe we'll ask to take off your shoes, especially in the winter time. But typically what I start off by doing is assessing your posture and standing, because the alignment of your body can dictate the function of your pelvic floor. After taking a look at that, I may look at how flexible are you? How flexible are you in your spine, in your trunk, pelvis, and hips? Because usually the pelvic floor, they can get a little tighter if the areas around it are tighter as well. And then after that, I may assess, on the other hand, like how strong are you? What kind of strength do you have in your abdominal core muscles, hip muscles, back muscles? Because pelvic floor, at the end, it is a core muscle. So it tends to overcompensate and try to do too much if you have core weakness as well. And then at the end, we may also assess your breathing pattern. Are you maybe a chest breather, or are you a belly breather? Because that can change the pressure into your whole abdominal region. Again, that can strain the pelvic floor. So those are some examples.
At some point, though, the pants are going to come off. And the experience is very different than what happens during a gynae exam. I mean, for starters, I want to be clear, there is no speculum involved, ever. And in fact, what most women notice first off is that the pelvic floor physical therapist spends a lot more time evaluating the vulva, the external genitalia, than most gynecologists do. So Helene, can you describe specifically what you're looking at and why you're looking at it?
So sometimes we're looking at the skin, where we're looking at, is there any irritation in the skin? Are there any fissures that could be cuts from if you're having intercourse and it's painful? But what we're really looking at is those outside muscles. So you can see here, actually, there's the clitoris up top, the urethra right below, and then the introitus, which is the entrance of your vagina. And you can see on both sides, there's actually these muscles coming down right there, right across here, and then right across here. And they each create a triangle on each side of these superficial muscles. And so what we might do is we might look to see, can they contract? Can they relax? What happens when you cough and you're putting a lot of pressure through those muscles? Can they actually hold? Which would be an indication of possibly why you're urinating when you're coughing. But then the other thing that we're looking at, are there any tender points that may give us some indication for why you may be having pain with the initial entry? But also maybe some of these are the reason for why you may have a diminished orgasm.
So what I'd like to move on to is talking about the internal work, because I think that's a real surprise for a lot of women when they go to pelvic floor PT and no one has really prepped them as we are now. And then when the therapist says, okay, I'm going to be putting my finger inside your vagina, they are completely blindsided. So Catherine, talk a little bit about the internal evaluation that you do at that initial visit.
Yes. So to fully assess the pelvic floor muscles, it is ideal for us to do an internal assessment. So as Helene was saying, we can look and get some information from the external muscles, but being able to do an internal assessment, whether that's vaginal or rectal, is very helpful for us. So as we've talked about, we don't use a speculum, we do not use stirrups, we don't have you scooch to the edge of the bed, we're usually on the side of the bed with you, or the table that we're on, and we use one gloved finger to assess the pelvic floor muscles. So how I like to explain it is that when you go to the gynecologist, they're looking more at the organs and some of the tissue quality and some of the other factors. While when you come to physical therapy and pelvic floor PT, we're assessing more of the musculature. So we're looking to see if there are areas of tension or tightness in those deeper internal muscles in addition to those external muscles, which again may be giving us pain, difficulty with urination or bowel movements, or lack of control in those functions. We're also looking at the strength of the muscles. So how well can we contract if you do a Kegel contraction, which most people have heard of, that's a contraction of those pelvic floor muscles, as well as our ability to coordinate. So what happens when you cough? What happens if you try and push down? What happens if you try and do a quick contraction? We'll also often look at nerve sensation and reflexes as well. But again, all of it's with one finger, and we're really assessing the muscles. They're just a little more internal with pelvic floor than they are, say, in your hamstring. So it seems a little bit odd that pelvic PT is in this realm. But what I always tell people is we're working on the muscles. We just have to get there through the vagina or the rectum, say if we, find that that's more appropriate as well.
Well, it's kind of like if someone went for physical therapy for their shoulder and the physical therapist never touched their shoulder, you would think, well, that's weird. So this is just, you have to go where the muscles are, and they happen to be on the inside. And while, of course, in our center, we only see women and only take care of women, I do want to just kind of mention at this point that men also benefit from pelvic floor physical therapy. All of you have trained to work with men, even though you're not doing that currently. And men do not have vaginas for the most part. And the work is done through the rectum, because people are always kind of wondering about, how do they get in there for the men internal muscles? They do. It is through the rectum. So after this initial evaluation, when someone comes for therapy, they're generally coming weekly, right? And so what's happening at those weekly sessions?
Yes, so the treatment that you receive is really determined by your evaluation. So it really varies greatly from patient to patient, but I'll just walk through an example. So if a patient comes back and the evaluation show that that patient has a lot of stiffness, not flexible, then on the first session, I might start off by using soft tissue, joint mobilization techniques, stretches to help you gain a little bit more flexibility. So there's better blood flow through your entire system and the pelvic floor muscles indirectly already. On the flip side, if someone had a lot more weakness during the evaluation that was determined, then I might start off by doing a little bit of core exercises to help you be a little bit more stable around the pelvic region. And sometimes that can help calm down the pelvic floor muscle sensitivity. And once there's better blood flow overall, then I may go into internal pelvic floor muscle releases. But again, that's not for everyone on the second session. We have many patients who do not do any internal work until third session, fourth session, if they have lots of sensitivity, or especially if they have history of trauma.
Yeah, and that's so important about individualizing the care, depending on not only what someone's diagnosis is, but what that person's past experience has been and what things are going to be significantly problematic for them. The other thing also is that when someone has PT for another part of the body, their shoulders and their hips, they're generally given exercises to do at home. Do you guys do that? I mean, how does someone exercise their pelvis at home? Catherine, tell us about the homework.
Yes, so just like traditional PT, we give you exercises and activities to work on at home. Some of these will include traditional kind of PT exercises. So again, kind of strengthening or stretching kind of exercises you might be more familiar with. But then we also include some other exercises, including work on diaphragmatic breathing. We might include some techniques at home, kind of self-release for those pelvic floor muscles, which might include the use of dilators or pelvic wands, or even your own hands. So just working on those muscles yourself can be helpful. We also tend to do a lot of work regarding bowel and bladder education and kind of lifestyle modifications, behavioral modifications that tend to make a big impact on symptoms as well. So yes, there is homework, and yes, it is helpful. Some of it traditional, some of it maybe not as traditional.
And my patients tell me I do my vagina homework every night. They're very motivated, I will say that, and very enthusiastic. We talked about a lot of the techniques that you use, which might sound kind of strange and scary for people. And I think one of the things that I get asked a lot is this kind of therapy painful? So Toshi, talk a little bit about what people are actually going to experience beyond the fact that it might seem weird or feel a little uncomfortable or just seem a little awkward. People actually have pain.
Right. So pelvic floor physical therapy really shouldn't be painful. So everything that we do in physical therapy should feel tolerable and safe to you. That is very important. So what I try to explain to the patient is that some of the techniques that we use, we may touch upon the edge of your pain. So there's a little bit of discomfort, but then we come off of it. So we're on that edge so that your brain gets a little bit of input that, hey, something has to change. Because if there's no input, then your brain really doesn't know that it's supposed to change something in the first place. But you're here in pelvic floor PT because you want to change the way how your body is today. So we touch upon the discomfort and come off. In terms of exercises, stretches that we do, the discomfort that you may feel really should be within like normal discomfort that you might feel with doing a deep hamstring stretch, and you feel a deep stretch. Maybe you're working on a muscle release using a tennis ball, really doing an exercise for the first time and feeling some exercise soreness after that. But it should be that kind of discomfort and not your pain that you do not tolerate well.
Yeah. And it's like anything else. The woman who's getting therapy always has the option to say, that hurts, please stop. I know you're always looking at faces, but now we have masks and that makes it a little bit tougher. So people really have to verbalize if something is feeling a little bit more uncomfortable than they would like. So at the end of all of this, I mean, we've talked about a lot of things, but what women really say to me is this going to work? Is this going to work? So as a sweeping generalization, knowing that every case is different, assuming that someone is in the hands of the right therapist and they're being consistent in terms of what they're supposed to be doing, how successful is pelvic floor physical therapy when it comes to the most common conditions we see, like incontinence and pain during intercourse? Lean, you want to grab that one?
Very, very successful. So the best part about this entire clinic is that we work as a team, but we're just one factor of it, and it's very successful. I mean, we work at your pace, we work at the speed that you want to go with, that your body, that you are personally comfortable with. And as long as we keep that dialogue open between both of us and that we work together, then it's extremely successful. As generally with physical therapy, what you can expect is when you're scheduling, you're going to schedule about 12 visits right off the bat. And the reason why we do that is just to make sure that you have continuity of care. We want to make sure that when we see you the first time, you already have a set time with us so that you can come back and we can continue to help you improve and get towards your goals. Sometimes people take a little bit longer than 12 visits, but sometimes people take shorter. And it just depends on how your care is going. But there is a resounding physical therapy can help.
Oh, I echo that and applaud you guys for the amazing work that you do. So one thing I just want to also talk about, in the center, we're always doing a lot of research. We're doing a lot of interesting things. It is very rare for someone who comes to see us that we're the first stop. Usually we're the second, third, fourth, or fifth opinion. Women have been to other pelvic floor physical therapists and quite frankly are always pleasantly surprised that their experience with our physical therapists is maybe very different than what they've had before because there is such a level of expertise and experience. But we're also doing a lot of research. And one of the things that Helene is doing right now that I want to have her just spend a minute talking about is some research in helping women who are having a difficult time with orgasm. So tell us about your work with that.
So orgasm is really important for all of us. And so I usually like to break down the orgasm into 3 different parts. There's the muscle, the nerve, and then the blood flow to the tissue. In physical therapy, I'm looking more at the muscle and the nerve function. But what I've found is that sometimes people come in with anorgasmia or the inability to have an orgasm, or they have a diminished orgasm. And what I've started to look at is actually the sensation around the clitoris. So you can actually find that when you do have a diminished orgasm, so clitoris is up here. What I've started to explore is that people will actually have diminished sensation surrounding that clitoral structure as well. And so there's a certain way that we can start to get those nerves to start to function a little bit better and become better at sensing any type of tactile cue, so touch to that area, so that the person may actually have the sensation and eventually get to that orgasm.
Now, Toshi, I know one of your areas of interest and your areas of expertise is doing visceral manipulation, which sounds really complicated. Tell us what that is and when you would do it.
Yeah, so visceral manipulation is a very gentle manual therapy technique to release the restrictions around your internal organs. So this is a very effective technique for someone coming in with GI issues, maybe abdominal bloating, inability to digest well. But really, it's for all symptoms if it's really strongly associated with a strong sympathetic nervous system response. What I mean by that is someone coming in saying that I have a lot of cramping pain in my pelvis, but at the same time, I feel like my whole body gets tight, I get sweaty. They have more like a global body response. It's also helpful for someone coming with symptoms associated with the big emotional response. So for example, they feel their rectal pain and they're really angry and upset about it. They're mad that they're in pain. So if you talk to a visceral practitioner, they will say that every restriction in our body has a structural component and an emotional component. So if someone's coming in with a big emotional component, then visceral manipulation and release can be really helpful. As the saying goes, you know, I felt my heart dropped, that was gut-wrenching. Those words exist because there is a connection between our internal organ state and our emotional state. For those people, visceral manipulation can be very helpful.
So Catherine, we see the tough cases. I mentioned that before. And a lot of women who walk into your office say, you know, this isn't going to work. I've already seen pelvic floor PT. This is a waste of time. What would you say to the woman who says, I don't think this is going to work, been there, done that, and it didn't help me?
Certainly. So me and the other PTs in this office have extra specialized training in pelvic health physical therapy. So we've gone on, I've completed a residency program where I basically went to an established program that has a pelvic floor PT program to get training just in this very specific area. In physical therapy school, we get a light dusting of it if we're lucky. And there are some PTs who will take a few continuing education courses in it, but maybe don't have as much of a full background in being immersed in the specialty area. So in our clinic, we see the tough cases of people who maybe have, you know, not encountered someone who works specifically in this area of PT as much. I think what also makes us different is our background knowledge of all the other forms of treatment that are helpful in addition to pelvic floor physical therapy when treating these complex conditions. So we know that the muscles are important and PT is very helpful, but making sure that they're appropriately, you know, getting medicated appropriately, or seeing the right providers, seeing other therapy in addition to physical therapy, seeing acupuncture and some of these other treatments are also very helpful. And in our specialty practice, in our training, we have learned a lot about that as well.
The other thing also, I think that you're really speaking to is the fact of how collaborative we are. I mean, where else have you worked where you are in the same physical space as the physicians, the advanced practice nurses? You know, we have sex therapists, and we all communicate on a regular basis because we're not compartmentalizing the patient into, oh, this is just your muscle and this is your tissue and these are your hormones. You know, we're putting it all together. And I have to tell you that I cannot count the number of times women have said to me, I was skeptical, I didn't think it was going to help, and my experience with these physical therapists was completely different than anything else I've ever experienced. And while we're on the topic of your training and your expertise, you guys have a lot of initials after your names. I mean, you have way more initials than I have. So which one of you wants to just jump in there and tell us? We know what PT means. I got you there, physical therapy, but we've got DBT, WCS, PRPC, OCS.
So my name, so PT basically just means that we have a license in physical therapy. DPT is our fancy way of saying that we all have our doctorates in physical therapy. We went through extra training to have our doctorate level. The OCS for me means that I'm a board certified orthopedic clinical specialist. So that takes another amount of schooling, either through residency or through extensive amounts of studying and practice in order to get that qualification. And then the WCS is a board certification clinical specialist in women's health specifically.
I'm impressed. I want to thank all of you for filling us in on what to expect when you sign up for pelvic floor physical therapy. To get an appointment with Colleen, Toshi, or Catherine, you will need a referral from one of our clinicians at the Northwestern Medicine Center for Sexual Medicine and Menopause. And like other kinds of physical therapy, it is generally covered by insurance. For more information on pelvic floor physical therapy, you can also check out my podcast, the Menopause Podcast, episode 39, A Personal Trainer for Your Pelvic Floor, when I have a fun conversation with Dr. Janelle Howell, another Northwestern Medicine PT.